Now we turn to the vote questions. And let's clarify first what our population of interest is for all of the questions. We're considering adult patients with hereditary transthyretin amyloidosis. So the first question is about inotersen. Is the evidence adequate to demonstrate that the net health benefit of inotersen plus care is superior to that provided by best supportive care alone?
HMO
Could just remind the panel what the evidence for that comparison says.
We had given inotersen an evidence rating of C+, and worsening of the MNIS +7 in the placebo arm, and we saw kind of stabilization, less worsening in the inotersen arm. In terms of safety, there were some safety concerns. All of the deaths in the inotersen, all of the deaths occurred in the inotersen arm. There was a concern about thrombocytopenia that was managed through monitoring, and then there was the fact that 30% of the inotersen arm developed anti-inotersen antibodies.
And on the benefit side, the quality of life scale followed a similar pattern
Exactly.
to the MNIS +7.
Exactly.
So any questions from the panel before the vote is taken? Or everybody feels ready to take their vote? Oh, there's one.
So just again, for my clarification, the evidence report considered changes in the scale scores to represent, even though there wasn't a clinically defined MID, the evidence team, when giving it the B+ rating, felt that that was clinically,
No,
or C+.
C+.
Okay, yeah. It was on the right side again.
Yeah.
Somehow considered that clinically good.
Yeah, that there's something there, something better.
Yeah,
We felt
other
that
than just
there
a
was
scale score, surrogate point measure. You felt your gut was that this was clinically good.
It was doing something clinically.
There's evidence of a benefit. The uncertainty comes in trying to understand the magnitude of that benefit. Okay, so any other questions? Are we ready to vote? We have 9 responses so far. Oh, all 11. Yeah. Okay, so 9 yes and 2 no. Would anyone who voted either way, yes or no, like to comment on why they voted the way they did? Let's take one of the no votes if you're interested. Okay. Oh, go ahead.
I'm skeptical, but I voted yes. I voted yes because of the gut feeling of the evidence team, the percentage of difference in these scale scores, and I was influenced by the input from other people around in this room here about some of that.
Okay. Any other comments? All right, let's move on to patisiran. Same wording. Is the evidence adequate to demonstrate that the net health benefit of patisiran plus best supportive care is superior to that provided by best supportive care alone? So Karen, can you just walk them through as a reminder?
Sure. So we gave patisiran a grade of B+ because disease progression was halted or improved with patisiran treatment across all primary and secondary endpoints. In general, there was a decreased frequency of adverse events compared to best supportive care. There were no differences in deaths between the treatment arms, but there is concern that all the deaths in the patisiran arm were cardiovascular in nature, and we had the issue of the complete heart block requiring pacemaker.
Any questions around the evidence profile for we vote? Okay, looks like 9 of you already have voted. 2 more? Oh, you have a question? No? You're all set? Okay. There we go. So 10 yes and 1 no. Okay. Again, anyone want to make a comment on why they voted in the direction they did? Jill.
I voted no, and here's why. Y'all didn't really comment on it where you commented on it in the write-up, but the generalizability was a problem that y'all pointed out, together with the lack of minimal clinically important differences, not knowing how to apply these changes in scales to something meaningful.
Okay. All right. So now we're voting on the possibility of comparing these two agents. Is the evidence adequate to distinguish the net health benefit between inotersen and patisiran when both are added to best supportive care? And Karen, can you remind the panel of whether or not we did any formal comparison?
No, we decided there were too many differences in the trial design, the trial populations, and the outcomes, so we felt we were unable to compare the two therapies.
That there were differences in the definition or the approach to best supportive care? Would that issue is, I mean, it sounds like you have three things, the reason you didn't do it, but is there a fourth that was raised by, I believe Spencer may have raised that point?
That best supportive care differed in the two trials?
That there was a point that was raised that, the approach to best supportive care was different in the two trials. I
didn't perceive that.
I did, well,
yeah,
that was an issue that was raised today.
Yeah.
Does anybody, no? Okay.
Okay, everyone ready to vote? 2 more responses needed. Okay. So 1 yes and 10 no. Would the panelists who voted yes like to comment? Okay. All right. So let's move on. Okay. So now we're going to talk about other benefits, and then in the slide after, contextual considerations. So you've got choices here. You can obviously vote on any and or all of them. So those other benefits are listed here. Reduce complexity that will significantly improve patient outcomes, will reduce important health disparities across multiple different domains and categories, significantly reduce caregiver or broader family burden, offers a novel mechanism of action or approach that will allow successful treatment of many patients who have not had success in the past, will have a significant impact on improving patients' ability to return to work and or their overall productivity, will have a significant positive impact outside the family, including on schools and communities, will have a significant impact on the entire infrastructure of care, including effects on screening for affected patients, on sensitization of clinicians, and on dissemination of understanding about the condition. That may revolutionize how patients are cared for in many ways that extend beyond the treatment itself. So note that some of these other benefits and considerations are specific to our ultra-rare adaptation, so you didn't see them for this morning's topic, but you see them here. And finally, at the grab all, there are other important benefits or disadvantages that should have an important role, and you can vote for that as well. So if people have questions, you can go through those. If not, you can certainly vote now. Sorry. Yes, talk amongst yourselves and with us.
So I have a question, and it's kind of related to the infrastructure of care and also about, so from what I hear from the clinical experts, it's about slowing the disease progression and keeping, symptoms and things from getting worse. Is there any discussion about starting earlier in the course of the disease, especially because many people would know that they, had a genetic mutation, and in that case, would it have larger implications for thinking about early identification and treatment that we haven't really discussed?
Oh, well, that's the Holy Grail. although it's important to understand that people are born with mutation, and yet the penetrance is incomplete, so we don't know which patients are going to go on to have disease. So potentially, in the absence of a blood marker that shows us when TTR is starting to misfold, you could bankrupt a medical system with treatments that perhaps are effectively more harmful at that stage than, and certainly not necessary throughout the life of a particular individual. So it's a noble pursuit, but a very complex implementation.
I'll make it simple. If we had a drug that was safe, effective, and cheap, you would treat the mutation. Now, John and I disagree a little bit about this on what the degree of penetrance is. I think we're coming to this conclusion in part from the experience with Alzheimer's disease, in that pathology starts 20 to 30 years before we see symptoms. And I think that there is a prototype study going on now in Alzheimer's disease that will allow us to answer that question and see if it's applicable to the transthyretin amyloidosis. And that is that people with dominantly inherited diseases that produce Alzheimer's disease are being followed from very early in life, and at a point in time, they're being given therapies that are presumed to work but haven't worked so far because they've been given too late in the course of the disease. So I think that's a very important example that we may use for this disease. But I still believe, and I said it before in public, is that a drug that was cheap, effective, and particularly safe, I would use it. There are many examples in clinical medicine where this is true. And if you ask the question about why do we treat hypercholesterolemia, we're not treating hypercholesterolemia, we're preventing myocardial infarction. Or why do we treat hypertension? Because we're preventing stroke. And why do all the physicians in this room take a baby aspirin? Because it reduces the frequency of myocardial infarction. And aspirin isn't even safe.
So other comments on some of these considerations? Ryan, you had your card up.
Yeah, I will not harp on it because it's the same thing I said this morning, but the report does indicate that there is the possible reduction in health disparities, and I strongly disagree with that. I think it will not reduce health disparities. In fact, it may increase them among the African American population because of higher rate of uninsurance, distrust of healthcare systems, racist healthcare systems, and so I see it as the opposite of what the report indicates.
Okay. Other comments on some of these other benefits, disadvantages?
So I'd just like to make a comment on
sure.
a few of these. I just want to stress that this patient population has a very significant unmet need, and there were a number of other potential benefits that weren't necessarily captured in the clinical evidence for these treatments, but we believe and the patient community believes should be taken into account when considering their overall value. These patients are experiencing high symptom burdens across multiple systems. The ability to have effective control over a disease could potentially limit the number of treatments these patients are taking to actually control their symptoms. Effective control could also support patients and caregivers remaining at work, retaining their independence, participating in family and wider life, and this piece about remaining at work, it's not just from a societal productivity viewpoint, but also it touches upon the personal financial losses and gains that these patients experience, as well as intangible benefits related to the anxiety, depression, and differences in family dynamics that come with not being able to work. The disease places a significant burden on family members as they provide physical and emotional care to their patients while experiencing their own toll that they're taking with the disease. And I mentioned earlier that they're often becoming part-time caregivers, part-time or full-time caregivers, which have consequences on their own work, social, and financial situations. These technologies are innovative in the way that they offer novel treatment approaches to this disease. To date, there are no alternatives that inhibit the production of transthyretin, thereby slowing the overall progression of the disease. And I think it's also important to consider when you think of other benefits and disadvantages, the positive impact that patients will have, the patient's perspectives on treatments and views on what meaningful outcomes are important to them are really important to consider here. Overall, from what we've heard from patients, the data that we've collected, the prospect for a treatment that slows or stabilizes the disease offers significant hope to these patients and their families. The most important factors to them are the ability of a treatment to slow the underlying disease and improve upon their symptoms. They really want significant outcomes, but they really highly value monitoring and improvements into their health. There was a clear basis for local and home. There was a clear preference for local and home-based therapies. Many patients and caregivers have had concerns about the amount of time they've had to take to travel to treatment centers to receive treatments. Both patisiran and inotersen offer the potential for home, local-based therapies valued by this patient group.
Okay. Tim.
I'd like to ask a procedural question, just trying to translate what's been presented in the evidence into this. For me, I'm just having to try and extrapolate, and I'm wondering what the processes are of, ICER and allowing the panel to step outside what was actually presented to get to A through G, or how many ever H's I guess you've got here. I mean, do we take the qualities and kind of say, okay, there's improvement in qualities, so therefore that's going to be an increased ability to return to work? Because we really don't have that data. We might believe it, but we don't have the data.
So this is your opportunity to step outside of what has been presented to you in terms of our interpretation of the objective data. So this is your opportunity to think about whether any of these other benefits might apply in your judgment. So we want to give our panels the opportunity to think about these considerations outside of what's presented in both clinical effectiveness and cost effectiveness sections.
And just to add, because it's a very good question. And again, we do change these questions a little bit for treatments of ultra-rare disorders. But the core issue is that we want to recognize and encourage discussion about potential benefits of care or disadvantages that cannot be captured by the current clinical evidence, even if there were better studies, or could not or are not captured by the cost effectiveness in some way. Now you'll see a lot of value judgments woven in here. So a lot of them say, well, it have a significant impact on improving productivity. Have any data at all, and so even if you had data, you might still not know what significant means. But the general issue is that we know that these tangible or intangible, they're very important to patients and their families and to others. The extent to which you will find them floating around your head when you're voting on long-term value for money, we think it's better to have it made more explicit and at least discussed and flagged, if you will, so that even if people outside this room might make different judgments, we hope that the general idea that people not just rivet down into the clinical studies and forget that there may be other benefits is an important to embody in our public meetings.
Okay, any more conversation, discussion? Reem.
Just a quick comment. I do think it depends, some of these are important. I suspect at least partially some of them are captured in the societal perspective analysis. And I don't know, Jeff, if you can speak to that. At least partially some are captured, I would say.
Just want to clarify, the purpose of this is to say, although the cost effectiveness analysis is going to look at the extra cost and the extra qualities, whatever that means, there may be other things of value that matter, other benefits. Maybe we'll call them other benefits. And you're wondering if people are thinking of these as some of the other benefits?
Well, I think Reem's point, so let's say, take E for example. If your societal perspective included changes in productivity, then that's not necessarily something that is outside of the analysis if it's already in the analysis.
Right, but the quality is not going to contain the improvements in productivity.
Well, some might argue it does. If quality of life is ascertained in a patient population and being able to return to work is part of that patient's consideration of their overall quality of life, there was a quality of life measure used in this trial, and that might have been reflected, as well as the SF-36 was used in at least one of the trials as well. So again, I think, Reem, it was an important point to raise because there is some overlap here. This, as Steve said, this is a value judgment. So if you think that our approach, our analysis, capture some of these or did not adequately capture some of these, and you think they are relevant to the topic at hand, then that's what you need to think about. Ryan?
I was just going to very quickly say a little caveat on this slide to maybe think about for the future is that the title says other benefits, but letter H includes disadvantages. And I will be marking H, and not because I believe there's other important benefits, but because I believe there's other important disadvantages.
Duly noted.
I distinctly remember a number of cases where a patient with LVH and diastolic heart failure who didn't have coronary disease and didn't have a history of hypertension but wasn't motivated to biopsy them because I didn't have therapy to offer them. So I think with respect to G here, I believe that when you have a novel therapy suddenly on the wavelength, we might answer some of the challenges that were mentioned by our patient advocates about the diagnosis being difficult to ascertain.
All right, so it looks like everyone has voted. Does anyone want to, oh, you're not done. Okay. Well, Tim is finishing. What was that? Oh, sorry.
Only I want to reiterate what was just said. I was in Israel last week and talking to the head of the Department of Genetics in Tel Aviv. He told me since these papers came out, he's been getting increasing inquiries from clinicians regarding the possibility of transthyretin peripheral neuropathy. So I think this impression that the availability of a new therapy or a successful therapy really increases the physician population to look harder.
You're good? Okay. All right, the votes have been taken. So the vote count is 3, 0, 10, 11, 8, 3, 4, and 4. So those who included some other benefits or disadvantages in letter H, would anyone like to enumerate what those were? Stacy.
It's just for a disadvantage, I think the long-term financial implications of being on treatment are probably pretty substantial. And also maintaining insurance, it sounds like there's a lot of concern around being able to work. And so I think that those would be difficult.
Okay. Other elements of letter H that people would like to discuss?
Yeah, I mean, ditto what Stacy just said, and I also, in terms of disadvantages, moved my B down to H in terms of, I think there are some racial components to other things such as insurance and socioeconomic status and access to health care that impact racial minorities in a disadvantaged way.
So rather than exacerbate some of those.
Exactly. Thank you.
Okay. Eric?
And I think it's obvious, but I mean, I think most of us chose item C, and I'd like to just make sure we're on the record recognizing that the analysis that was undertaken, cannot get at the impact this has on inherited family disease and the burden that it has to the caregivers. And I don't even like calling it burden. I mean, this is what people do for people that they love. And so, but I just want to make sure that we clearly reflect the inadequacies of the report to address this family condition.
Yeah, and I just want to add to that, I think it's insulting to use the word burden. My wife would not say I'm a burden to her if she were ever have to change my diaper. Just like if my kid had cancer, it wouldn't be a burden that I have to do that. So I think it's negatively framing a question that probably skews an outcome if someone can't see through the connotation behind the word.
Okay, Harold.
I do think that the dimension of hope that therapies like this provide is very significant, and that was something that I wasn't exactly. It's partly C, it's partly H, but especially given the inherited family nature of this, that's something that I found very significant.
Don, you had a. Oh, you're all set. Okay. All right, so let's move on to contextual considerations. Again, this is for both of the active agents. A, intended for the care of individuals with a condition of high severity. B, intended for the care, not the cart, sorry about that, of individuals with a high lifetime burden of illness. The first to offer any improvement for patients with this condition. Compared to best supportive care, there's certainty about the long-term risk of serious side effects for this intervention, or these interventions. And compared to best supportive care, there's also significant uncertainty about the magnitude or durability of the long-term benefits. And then also another catch-all, additional contextual considerations that should have an important role in the judgments of the value of the intervention.
Could I comment very quickly on generalizability? Sure. I know it's been mentioned several times. However, in supplemental reporting for one of the trials, if not both, the forest plot analysis shows that regardless of mutation, there's significant benefit by modified NIS plus 7. So I think these are generalizable data. And with regard to PACER placement, that is part of the disease. And if you deal with enough of these patients, you're going to see it. I think it's a little unfortunate that it's been couched in the setting of use of an investigational product, and therefore shrouded with some mystery. It's not mysterious. This is what happens. And these people do die of amyloid in the heart.
But presumably you'd expect the rate then not to differ between arms if this is a feature of the disease.
In this case, I would agree with John. I think at this point particularly that when you look across these two studies, that the degree of generalizability and the outcomes, location doesn't make any difference. The nature of the mutation, for the most part, doesn't make any difference in the way they respond to these drugs. And was the one real objection I had to the preliminary draft is that I thought that for the essence of the diseases, the two studies were extraordinarily comparable. Or I must confess that the editor of the New England Journal did not agree with me.
Okay.
Ask a quick question of ICER. In the report for E, the report says none identified, and I want to make sure I'm understanding E right. So it says there's significant uncertainty about the magnitude or durability of the long-term benefits. But to me, there is uncertainty. Like, we don't know at this point whether these drugs will, I mean, right now it's looking really promising, but who's to say that if you're on one of these drugs for 6 years that all of a sudden you don't jump to the placebo group? I don't know. I just don't know if the evidence is there because it's so new. Or is it
So I'll tell you how to add it if it's any help.
Thank you. Yeah.
So I thought given the progressive nature of this condition, the durability that was observed during the studies that are available was kind of long enough for me to say, that's pretty durable. Like, I guess I didn't come in with an expectation that, for a 5 or 10 or 15 year durability. I think there's some uncertainty about it, but I think, to me, there's much more uncertainty around the risks that are just unknown with this particular, like, we're talking about new technology here. And while we'd love to think that it's perfectly safe, we may find out that it's not.
I guess that's a good question for us, and maybe we as a group can talk. I mean, it sounds like you're thinking about it within the research studies that were presented. Is there durability?
Well, yeah, I would say that I saw it that way, and I did, in my own mind, extrapolate the duration of the study to be reasonable in the condition that's under study.
I can speak for the patients here, if I may, for a second.
Unfortunately, we need to actually keep this conversation to the panel. We can certainly bring you into the conversation during the roundtable discussion.
Okay.
Thanks.
Just real briefly, because I want to make sure you have plenty of time for the roundtable. The questions on both potential other benefits and contextual issues are there to capture some certain situations and don't necessarily apply equally to every single intervention you will look at. So the reason that question is there is partly from clinicians and payers that some new drugs are using a similar mechanism of action, or for other reasons you have a lot of certainty that the benefits you're seeing in 6 months or whatever are very likely to continue for whatever duration of time you would intend, whereas other new medications are lots of different ways, may be very exciting and the short-term benefits are very substantial, but you have a lot of uncertainty about what really happens in years 5, 10, 15. So we're seeing this more often as we see treatments that can sometimes be called potential cures and have, again, tremendous short-term effects with high uncertainty. It's mainly to kind of capture that and, if you will, the benefits sometimes of a Me Too drug, where we actually have more certainty just based on the fact that we've seen drugs like this, similar mechanisms of action, maybe a slightly different indication. So it's meant to help reflect some of that difference.
I was just going to add, I think one uncertainty with inotersen was that development of anti-inotersen antibodies in 30% of the patients. So once you develop antibodies, will the treatment still be effective?
So if I can just comment from the patient's perspective on the long-term risks and the potential risks of these treatments, because we've talked to quite a few patients about their preferences and their considerations when thinking about these two drugs. And I will say that I don't think we agree with the level of weight or uncertainty around the risks of thrombocytopenia and the long-term steroid use with patisiran. I do think from patients' perspective, these are well managed, and I think it's important to keep in mind that best supportive care allows for treatment progression or for disease progression. And these patients know exactly what this disease progression is going to look like for them, and so I think they are willing to a degree to trade off on some risks if it means actually slowing the underlying disease.
Other comments, discussion points from the panel? No. Oh, we have 11 responses. Sorry, I didn't even see that. Okay, so here we had much more populated responses. So 10 for high severity, 11 for burden of illness, 8 first offer any improvement, 9 uncertainty about long-term risks, and uncertainty around long-term benefits, additional contextual considerations that should have an important role. Would anybody like to elaborate on what those additional considerations might be? Nobody. Okay, there's only 2 of you.
I wanted to say why I voted for C, based on our discussion this morning. So, because part of what you said was that why many of us didn't vote C for the therapy this morning was that there were effective treatments, though not specifically to what we were looking at or that kind of drug. Here I voted for it because what I understood, the only other available treatment was liver transplant. And that's just not being used, it's just not very available. So to me, this seemed like a brand new option that really could be used for people in liver transplant. So that was the rationale behind it. Tell me if I'm wrong in that way of thinking about it.
You're in good company. Okay. All right, so let's move on to our value votes. So here, just as a reminder, we're now talking about long-term value for money. So as Jeff so eloquently put it, the money spent to achieve essentially a year of perfect health, a QALY. So first focusing on inotersen. So for adults with hATTR, given the available evidence on comparative clinical effectiveness and the incremental cost-effectiveness results that Jeff presented, and considering other benefits and contextual considerations that we just discussed, what's the long-term value for money of inotersen plus best care compared with best supportive care alone? And Jeff, could you remind the panel of what the results of our primary analysis indicate? Yes. You're talking about one of those light parts, right? Inotersen. Microphone.
That was my pausing technique. So for inotersen versus best supportive care, the incremental cost-effectiveness ratio was about $1.7 million per one additional QALY. And for patisiran versus...
We'll get to patisiran in a minute. Okay. Any questions for Jeff or for the other experts, patient representatives, before this vote is taken? Harold.
Just to comment that I would use the $500,000. I would use the $500,000 threshold myself, given the circumstances, as the yardstick. Just to put that out, given the nature of the.
Okay. Well, it's important to remember that our approach is not to use any different standard than we use when we're dealing with a non-ultra rare condition, but we do present additional information, recognizing that policy use different thresholds. So, I mean, everyone has an individual choice to make, but I just wanted to make sure that everyone understood that. It's not as though we're presenting a different threshold to vote on. Okay. Aaron.
This almost feels like a defense before I vote, but you know, a vote can come out by talking about how much impact we think the drug can have on people's lives, or it can come out as how much does this cost, obviously, clearly, versus how much of an impact we're having on people's lives. And I have to agree, I understand like there's different thresholds, but you know, in our heads, 500,000 seems, while it's much larger than would normally be, a lot of money to spend for a QALY. And so at 1.7 million, that's a lot of money, and it's more of a, I think it's important to say in a vote of intermediate or low here, maybe much more pointed at the cost of the drug, how much of a difference we think it might make in people's lives.
Greg.
But understand that the modeling was dependent on a certain understanding, maybe that is difficult, of how impactful the drug is. So when you look at that modeling number, I think you need to have a little bit of perspective.
And while I would agree with that, $1.7 million per QALY, even if the utility went up significantly, would still be well over $500,000 per QALY. So even in my head, when I give it some leeway in terms of how much unmeasured improved utility there is, that's a very high number, and perhaps is more of an indication of how expensive this is compared to other treatments versus how much of a difference it might make in people's lives.
Also recall that Jeff acknowledged and tested that uncertainty in his analysis, so that's an important consideration as well. You've got your evidence summaries, and so you have some of that information available to you. Greg.
Earlier we were given a figure of $2.5 billion for research and development, and you know, I don't know whether to believe that figure or where it comes from or how we would validate it. And I know that doesn't factor in formally into the calculations, but should we be thinking about this at all?
Can I add to that before you answer it? Because I did the math calculation. So let's say that's a true number, 2.5 billion. The manufacturers had no problem with the price of $345,000. I am not naive enough to know, I know that they would not get that full amount, but let's say they did. The manufacturer would have to only have 7,500 patients worldwide on this drug for 1 year to make back their $2.5 billion. This is the same week, I'm going on a soapbox a little bit, where we had a pharma executive say that they felt they had a moral their shareholders to increase prices of drugs. So to me, it's coming into play with this.
Thanks for doing the back of the envelope, Ryan. Okay, other comments before taken? Okay, let's go. Some of you've already done it. All right, all responses in. So unanimous, low value. Okay. So now we're moving from inotersen to patisiran. Same wording for adults with hATTR, given the available evidence on comparative clinical effectiveness and incremental cost effectiveness, and considering other benefits and contextual considerations, what is the long-term value for money of patisiran plus best supportive care compared with best supportive? So Jeff, sorry, can you remind them of the results?
So for the cost effectiveness, one of those 4 parts you're considering, the estimate was $835,000 per additional quality.
I think is just a minor correction on one thing based on Ryan's comment from before. So the $345,000 is actually a published estimate of net price, not full price. Tim.
And again, on some of your sensitivity analyses, you found really nearly nothing that got it below the, there were a few scenarios that it brought it below the 500,000, is that correct? Probably few is an exaggeration. Do you got any percent, what is 5% so you'd have to make large assumptions to get it under 5,000, and there are rare situations in which it actually was under 5,000, correct?
500.
So the quickest way to reduce the cost effectiveness ratio is to improve the effectiveness or to decrease the cost. And the fastest way to decrease the cost would be, of the variables we looked at, to decrease the price of the drug. Remember, it's $345,000 a year. So if best supportive care is 0 and this drug gives you 1 life, then your delta E, your extra effect is 1, and you're going to be getting $345,000 extra cost. So that's the dynamic we're playing with. The tornado diagrams can show you the variables that we varied.
Questions? No? Okay, why don't we vote? Almost there. One more. Okay. So also with patisiran, 11 low value, 0 the other categories. Okay, so would anyone like to make a comment on this? No. So that concludes our voting. Oh, okay.
Just because I want to make sure that the language here doesn't get too much in the way of the message. And I want to acknowledge the people who've come and testified today and the people who've worked with us throughout the entire report. I know they've spoken to this before. before and the people who've commented today. Calling something low value can feel incredibly disempowering and disrespectful. We know that. That's why it's so hard but important to try to distinguish between value to patients and to doctors and to families and even to our communities and what we mean by value for money. Because if we all were here at $345,000, if we were all here and it was $34,500, we'd be having a very different conversation. If it were $3.45 million, we'd be having a different conversation. So the question always comes down to whatever we can do about grasping that value, how much is a price that would be aligned with the benefit for patients in the community. So I just want to send the signal that I recognize the hurt with the language and the votes, especially if taken out of context. And the votes that were on the potential other benefits and the contextual considerations are critically important to our report and to the meaning that we hope to convey in our executive summaries and other materials. So I know that this is a prelude to policy roundtable, but I just felt like I could just feel the impact of these votes on people who have suffered and who will see their children suffer. And I just, all of us as individuals want to recognize what you are going through and how wonderful it is to have new available treatments. And hopefully we can make them more accessible and affordable. And that's what the topic of the policy roundtable will be.
Thanks, Steve. Well said.